My name is Ali McHugh, and this is a quality improvement project on ventilator-associated pneumonia in the population of critical care patients. Ventilator-associated pneumonia, or VAP, is an infection acquired from mechanical ventilators in hospital settings that causes longer hospital stays, higher mortality rates, and higher costs for hospitals due to the increased level of care needed. These are acquired from mechanical ventilators often used in intensive care units and other critical care settings. Patients in the intensive care unit are at a high risk for acquiring VAP due to many conditions preventing mobilization and deep breathing, and they also require long use of mechanical ventilation more often. In 2015, about 687,000 hospital-acquired infections happened in critical care settings. VAP is one of the most commonly occurring hospital-acquired infections in critical care. A survey of acute care hospitals showed that pneumonia is the most common infection, and 32% of those infections were VAP. In the survey, it was found that about 50% of antibiotics in the critical care unit are for VAP. The risk of VAP increases about 1 to 3% every day a patient is intubated. Inconsistency and lack of compliance to protocol for prevention lead to an increased risk of VAP. This is a cause and effect diagram. So over here we have all leading to a reduced number of patients acquiring VAP. So these are all prevention measures that nurses and institutions can make to create a lower number of patients acquiring VAP. So first we have hygiene. Oral hygiene is important when patients are on a ventilator to reduce the amount of bacteria in the mouth that can go into the lungs. So we have oral hygiene and then proper hand washing for any healthcare worker coming into contact with the patient. For positioning, we have the recumbent position as a way to help reduce VAP, and it has been shown that increasing the head of the bed to above 30 degrees helps to reduce instances of VAP in patients who are ventilated. Preventing other hospital-acquired injuries helps reduce the incidence of infection, and so this helps reduce VAP that way. So there's peptic ulcer prevention. This is often done in the hospital using PPIs, or proton pump inhibitors, and venous thromboembolism, or DVT, deep venous thromboembolism prevention, is usually done in the hospital with anticoagulants. And then assessment of progress, because like I said in the last one, every day that a patient is intubated and on a ventilator increases their risk of acquiring VAP by 1 to 3%. So getting them off the ventilator as soon as they can safely is important to reduce the risk of VAP. So using weaning assessments and breathing trials to assess the patient's progress and being able to breathe on their own helps to reduce the risk of VAP. And then for institutions, compliance is most important in implementing any change, because compliance is what makes it happen. So instituting a protocol is obviously important, but making sure that staff are compliant to prevention measures helps reduce VAP the most. And then education on compliance importance and staff education is very important, because knowing you should do something and knowing how to do something are very different. And understanding the importance and its effect is very important for staff to make that change. So we have VAP bundles as a plan to reduce VAP in hospitals. VAP bundles are already implemented in a lot of hospitals, but it is important that every hospital who has patients who are on ventilators implements VAP bundles. So VAP bundles are guidelines for prevention of VAP published by the Institute for Healthcare Improvement. These are different between different hospitals, but they usually include oral hygiene, peptic ulcer, and deep vein thrombosis or DVT prevention, the elevation of the head of the hospital bed greater than 30 degrees, and weaning assessments with sedation disruption to get patients off of ventilators as soon as it's safe for them. And then the use of these bundles has been shown to reduce the occurrence of VAP by 44 to 54%, so that is very significant. And consistency and assessment of compliance are essential to success in reducing rates of VAP in critical care units. Education for nurses on these bundles helps improve that compliance so that they feel more confident in what they are doing. And education on VAP and knowledge of VAP bundles is essential to reducing VAP rates in critical care units. So the use of VAP prevention bundles has been found to be very effective in preventing VAP when compliance is high. But what are some boundaries to compliance? Non-compliance and lack of documentation have been a problem in the past before implementing quality improvement projects. Prior to quality improvement projects, gaps in knowledge contributed to a lack of compliance. Although VAP prevention bundles had been implemented in these hospitals, they were not well understood by nurses, which may mean that some nurses did not attempt them or were doing them wrong because they did not clearly understand what they were to be doing. Education and training yield higher compliance with VAP prevention bundles. Higher compliance after intervention has led to lower rates of VAP in patients. Low staffing can also negatively increase compliance because that means less time and energy that they have available to complete these seemingly small tasks. So some process data that some of these studies have, all of them focused on education for staff members on VAP bundles. One study focused on education related to pulmonology care for patients. It assessed nurses during their care for ventilated patients and educated during the assessment on improvements that they could make. Another study used a presentation and teach-back method to educate nurses on oral care and charting for VAP prevention. The last study provided lectures on VAP bundles and enforced strict compliance for their nurses. And then for the outcome data that these studies provided, one measured results through electronic charting to measure changes in outcome. The percentage of ventilated patients who acquired VAP went from 20.8% before intervention to 12.2% in shorter hospital stays for those patients. Another study got results from chart review, so pretty similar to the last one. Days on the ventilator decreased, patients had shorter ICU stays, and VAP diagnoses went from 44% of patients who were ventilated to 29% of patients. 29.1% of patients. Results from the last study were determined through multiple hospital sources. Compliance improved over 2 years after it was implemented to 90% and then 100% in 3 years. A lot of this also is because it becomes the new normal for that unit's environment. So nurses feel more comfortable doing it and they're taught to do it from the start. VAP rates were 12% before the intervention, 3% 2 years after, and 0% 4 years after for this hospital, which is a really high achievement. So how can hospitals act on this issue? Implementing hospital policies to require the use of VAP prevention bundles can promote compliance. However, this is not enough because staff may not understand VAP prevention bundles, which can lead to lower compliance. A policy requiring yearly attendance of meetings or lectures to teach staff about VAP prevention and risks of VAP can improve compliance and understanding for nurses. In one study, the hospital had already implemented VAP bundles, but compliance was low before education. compliance was 65% a year after, 90% 2 years after, and 100% 3 years after. In all of the studies used, improvements in patients who acquired VAP were only seen after the implementation of education for staff members. In one study, nurses continued to be encouraged to attend meetings and were required to attend lectures regularly. Another study recommended this education be included in yearly education renewal. Here are the references used.